What's going on, everybody? Welcome back to Crashcart Nursing. I'm Nick McAllister here with Courtney Wong. Today, we got all kinds of fun stuff that we're going to be talking about in our podcast, going over some different ways of communication. Communication is so important to everything that we do as nurses, and we're going to show you the right ways.
Okay, guys. So before we get started and kind of get into the meat of communication, we just want to start off with breaking down what even is nursing communication. So gold standard in healthcare is we use SBAR communication. So SBAR communication stands for situation, background, assessment, and either recommendation or requests. And the reason we use this, fun fact, this was actually developed and utilized by the US military, which I learned not too long ago. So I thought that was pretty neat. But we use SBAR communication so that way, anytime we are communicating with anyone in healthcare, it's done in a standard way, and everybody knows exactly what's going on with the patient. So starting with S, right? This is going to be our situation. So why are we even communicating? What's going on, right? What's happening with the patient? It's usually going to always begin with the identity of you, right? Hey, my name's Courtney. I'm calling from the ICU. Then we're going to move on to the patient, right? So make sure you're identifying the patient that we're calling about. These are going to be like the patient's names, right? You're going to want to make sure you say the age and the gender of the patient and just kind of a brief overview, right, of why we're calling. Then we're going to move on to the B part, which is background. So background is going to cover the clinical background, right? The patient's history that's related to the current situation, right? Or any symptoms of the presenting complaint that we are calling about. So this could be a temperature, right? It could be test results. It could be any type of lab imaging results, something like that. Then we'll move on to our assessment. What do you think the problem is? What are you seeing that has occurred? So then we'll move on to our assessment, right? And our assessment is just that objective data that we are seeing that is now leading to this call. So this could be, your patient has the temperature, but they're also diaphoretic, right? We're seeing maybe a little bit of lethargy. This is going to be all of that good assessment finding objective data that you have seen. And then we're going to move on to our R. Our R is going to be our recommendations or our requests. So this is going to be the time where if you're calling a provider and providing an SBAR report, this is going to be when you're going to say, are there any type of medications that you'd like to give? Are we going to give an antipyretic? Do you at this point, before you've gotten to your R, by the way, just note, you have already done kind of your nursing scope interventions, right? But your R is going to be, this is what I'm recommending. This is the request that I'm asking for. If we're talking about a fever, some type of medication that we're going to be wanting to give the patient, or we're going to ask the doctor if there's anything that they want to do to treat the fever.
Absolutely. And the thing is with SBAR is when we're doing this, obviously this is a uniform way of communicating and everybody knows and expects it. And we want to, I think a lot of students kind of get off in the weeds because they think, well, I have to include everything that's ever happened to this patient. Well, newsflash, you might be dealing with somebody who's in their 90s and their life has been very, very long.
Yes.
So be concise.
Very sick.
Yeah, be concise. There's a lot of things that have gone on. What happened to them when they were 12 doesn't matter. What we're trying to get at is what is happening today. So this is the situation. This is the background of what's going on today. This is my assessment from today. And this is my recommendation or request. And I will tell you, there are some providers that don't love it when we give a recommendation because they think that we're trying to do their job. So we want to tread lightly with this. We want to be careful with this. I had one particular doctor that I worked with in the emergency, and he's a great doctor. He's a super smart guy, a little tough to deal with sometimes. Yeah, I found in my clinical practice, even as an experienced nurse, that if I gave a recommendation, he would absolutely do everything in his power to do the opposite.
Yes.
Even if the thing I was asking for was the right thing. I swear to God, we would end up back at that thing that I wanted the whole time. But I learned that if I just leave the recommendation off, I would say, what would you like to do, doctor? And it would almost always be the thing that I wanted. And if I
Mhm.
asked for
Right.
it, I was not getting it. So you got to learn your providers. This is some of that nuance of learning how to be a healthcare provider, and it takes time, and it's okay. And you're going to take your licks sometimes. Sometimes the providers might be a little bit catty about it. They might be a little bit of a douche, and you're going to deal with it, and it's going to be okay.
It's gonna be okay. It's funny because we were actually just talking about this in sim the other day because it was the first time with me, right, as Dr. Courtney. That's what I make them call me, is Dr. Courtney and Sim. And it was the first time they were having to call me for SBAR, and I actually told them the same exact thing. I'm like, sometimes you're gonna ask and they're just not gonna give it to you out of spite.
Exactly.
Like you have to build those relationships, right? And kind of, as horrible as it is, sometimes you just kind of have to earn the standing. So, yeah, guys, learn your providers and you'll be fine. But honestly, also, if they're going to be mad, they're going to be mad. I also
Yeah.
tell my students that, like, let them be mad. If they aren't your boss, they're
Well,
your
and keep in
coworker.
mind
Mm
this too, is that your goal as a nurse is to advocate on behalf of your patients.
hmm.
It's not always to be best buddies with the provider. Like, yes, we
Yeah.
want to be able to work well interpersonally with other departments. We want to be able to work well with providers. We're all on the same team. But at the end of the
Mm
day, the thing that makes me a prudent, good nurse is that I advocate for my patients when
hmm.
I
Mm
need
hmm.
to, that I ask for things that are appropriate, and but ultimately it's not my license as far as the ordering of whatever medication. I can give recommendations, and part of the reason why the providers have this like hang up is because there is totally times when nurses ask for
Mm hmm.
stuff that is just inappropriate, when it's like you're off in left field and they're like, we're over here and you're way over there, like that's
Mm hmm.
so far out there, it's not the right thought process. But a really good thing that you can say in those situations is, would you teach me about why we wouldn't do that?
Yes. Oh my god, that's my favorite, dude. That is my favorite way to like approach some of those little bit more difficult to approach physicians is, well, can you talk me through that? I would love to learn
Yeah,
about that
absolutely.
cuz doctors love teaching. They
Yeah,
love teaching.
I love a video that Jen Hamilton did about this, and because
Love her. Grits.
one of the ways
She's my
that she
best.
says it is, she talks about this story in the ER with where she's charging, and this new nurse is about to give insulin, and she goes, "Hey, can you come and co-sign some insulin for me?" And she's like, "Sure, yeah. Why are we giving insulin? What's going on? You know?" And
Mhm.
she sees this just like mega high dose of insulin, and Jen goes, "Why are we giving this patient this much insulin? This is a lot of insulin. Like, what was the blood sugar?" And the nurse goes, I don't know. It's just what the doctor ordered." Well, first off, please don't just give medications that you don't know why you're giving them. That's not a
Mhm.
good habit. And then, second off, she said, "Come with me. I'm going to teach you what we're going to do." And she walked over to the doctor and she said, "Excuse me, doctor, could you teach me why we are giving 100 units of rapid acting insulin to this 18-year-old patient that's non diabetic?" And it immediately perked him up, and he turned around and he's like, "Excuse me, I did not order that. Please do not give that," you know. And it turned into a correction of a near miss, right? I mean, so that is a near miss, and that should be
Yeah.
documented. How did this happen? We need to do a root cause analysis. But that's getting off into a whole nother subject. But the point is that when we don't know something, we should ask. And then
Mhm.
if there's a request in SBAR that you give and you wanted something and they said no, we want to figure out a way to ask that and be like, I just want to understand rationale so that I am not
Mhm.
asking the same question over and over again in times when it's inappropriate. This is part of our education in our nursing practice, is doing that. And I think just learning from your providers is so huge. They are a huge resource. And if they can be in your corner and be on your team, like, you will be so much
Yeah.
smarter for it.
Yeah. I learn things all the time from some of my doctor buddies at my old job. Because they are, I mean, they are really smart, right? And it's kind of cool sometimes to, even if you're asking because you think, hey, this is what I really want, sometimes they do actually give you like an outside perspective, like a medical
Hmm.
perspective rather than a nursing perspective, and you just learn some cool shit, you know what I mean?
Yeah, and then that's how you become a badass nurse. I mean, honestly,
Mhm.
is
Yeah.
from learning in those situations. And I always tell the docs this: if I ask them to teach me about something, part of the reason I'm telling them that I want to learn about this is because I want to hear, like, I like hearing the way that they teach their patients, because once I hear them teach a patient how to, about something, like, say we're just talking about like chest pain or something, and they're like, hey, you know, a chest pain, it can take up to 6 hours for a troponin level to rise in a regular troponin, not the high sensitivity troponin.
Mm-hmm.
When they're teaching that, I can listen to the way that they say it to their patient, and then I can echo that same thing to other patients who are waiting on the same result, or whatever. You know what I mean? Like, and it doesn't have to just be that, it can be anything. And so when we hear the way that they like to explain stuff to their patient, if you can emulate that, it makes it less work for them. Or
Mm-hmm.
some of them are not super great at communicating because they have a little bit more aggressive form of autism than I do. And
Yeah.
so like, so I can help fill in the blanks, right? And
Yeah.
like help with some of that communication, the interpersonal stuff that maybe that they struggle with. So they explain the science, and then I can be like, okay, now we're going to break this down like a real person is listening to this,
Mm-hmm.
not somebody with a ridiculous amount of medical education. So
Yeah, right. And then Nick, I kind of want to, because you said something really interesting that I want to point out to them, and that's going back to talking about what that video with Jen, right? Because I like what you said with the, like, hey, can you teach this back to me? And then she repeated the order, right, that she had seen. That is also really important to do when you're in any type of communication with a doctor, right? Read back. That's a big
yes,
thing that you hear when you're in lecture and you're hearing us talk about all of these documentation things or whatever. But read back. That's really important, and that is why that is
yeah.
important, guys.
Well, and so that's in readback applies in multiple different ways, right?
Mm-hmm.
So like we have readback in a situation where if we have a critical situation and they're giving us a verbal order, you always are
Mm-hmm.
going to give readback. And what that looks like is that closed loop communication where it's like doctors like, hey, Courtney, I want you to give 1 milligram of Epi IV push now.
Mm-hmm.
And then so you're going to repeat that
And you
back to
read it
me.
back.
Yeah. And so Courtney's gonna come back and say, okay, I'm gonna give 1 milligram of epinephrine IV push now. And then there's no confusion of
Mm-hmm.
I gave the order, she accepted the order, she read it back to me and told me what it was. And then we take it one step further. Then it's when I actually give that epinephrine in that code situation, then it's 1 milligram of epinephrine given. And then that's
Yes.
getting written down
Yes.
by our recorder, and so it's always this closed loop communication of
Always.
the provider opened the channel and said, hey, I need you to give this. And if we can look somebody in the eye, so sometimes you know your team, you know everybody by name. Sometimes you do not. But communication standards in these situations, especially critical situations, is if I don't know your name, I at least get your attention and we make eye contact. And when we
Mm-hmm.
make eye contact, I say, hey, I need you to do this, and you say, copy that, I'm going to do this, and you read it back. And then once it's done, it's, I did that thing.
Yeah.
So it's always going to needs to be like that in, especially in critical situations, but anything where there is just verbal communication going on. So if you're on the phone and you get a phone order, it's the same thing. And I've had doctors where it's like, hey, can you give 4 milligrams of Zofran? And we're also going to do a 30 milligram IM injection of ketorolac, and they rattle off 10 different things really quick, and you're like, holy shit, I can't write fast enough. And when that happens, you can tell them to slow down, like, hey, I'm writing this down, I'm getting these orders
Mm-hmm.
put in, and then I'm going to read them back to you. So you said 4 milligrams of Zofran IV push one time, you said 30 milligrams of ketorolac IM injection one time, is that correct? And when they say, yes, that's correct, or no, actually, let's change the dosing on that, or actually, let's change to a different medication. If they give you something different, we're going to read it back again. And this just
Mm-hmm.
helps protect you. And prudent nurses, diligent nurses are going to do this readback communication. It's a standardized thing, and it's there to keep you safe.
Yes. And you want to make sure too in this closed loop communication, especially with orders, because you don't really use them quite as much in like a lower acuity setting, right? Where there's kind of this like practice now where they're really, really pushing providers into writing their own orders. And so
Yes.
on a lower acuity floor, you don't see this as much, but it is just as important. In higher acuity situations, right? Like the ICU, the ER, kind of these situations where you're like running codes, honestly, is kind of where all of this comes together, and it has to work
Yes.
to get everybody on the same page. But when you're working these critical situations, whether you're running like a level 1 rapid infuser,
Mm,
or you're doing a code and you're giving amiodarone and an epi and your bicarb and you're like pushing all of these things, it becomes really important that you are repeating everything. So
yeah.
if you get an order from a doctor and you're reading it back, we're not saying, okay, we're going to give 15 of Toradol. No, it is,
Yeah.
we are giving Toradol 15 milligrams IV now, right? Like we want to make
Correct.
sure that we are repeating the entire thing, because God forbid, right? You're giving, I don't even know, like a nitro, right? You might say, oh, we're going to give nitro, but the doctor actually wanted the paste and you gave the tablet,
Yeah, and
right?
that's another key important part of why CPOE, a computer provider order entry, is so important, because when providers put their orders in on the computer, the benefit is that they can look at what's the route, they can look at all
Mhm.
this stuff. And when you have time, this should be getting approved by pharmacy in most places. Obviously, I know like there's outliers to this and not everywhere has this technology. You can come for me in the comments if you want. And that's totally fine. I like the engagement, so do it. But the thing is that when a provider does that order entry, it goes to pharmacy. Pharmacy approves it, and pharmacy will product select. And so what that is doing is it is making it to where when you go to your Omnicell or your Pyxis, or when you go to whatever med dispenser that you have in your facility, that the correct product is picked. Because it
Mhm.
is so common that people will make a medication error just because they pick the wrong product. This is why it's a national patient safety standard to have product selection being done by a pharmacist to make sure we're giving the right product for the right thing. You can either pick it from a 1 milligram vial, a 4 milligram vial, or a 10 milligram vial. And it's very simple. If people are looking at, oh, well, this says give 2 milliliters of morphine and you've got a 10 per one, or you have a 4 per one, right? Their concentration is different. So it's possible to make a med error. And if you
Mhm.
just are focused on, oh, I just give 1 mil of morphine, well, 1 milliliter of morphine could be 4 milligrams, or it could be 10 milligrams, or it could be one
Mhm.
milligram. And you could either be underdosing a patient or overdosing them. And either way is problematic. So, this is why it's so important that we go through these processes. So, not exactly communication, but it is communication because of the fact that that CPOE matters. That the provider putting that
Right.
order in is the best practice. But obviously, there's times where verbal orders really need to make sense. And I was watching a creator recently talk about verbal orders, and I thought that one of the things that she said, her name's Alana. You should follow her because she has really good content. I'll actually tag her in this. But one of the things that she said is talking about verbal orders. You do not have to take verbal orders from everybody. You can refuse to take a verbal order, especially if it's not a time
Yes.
where it needs to happen. You can say, I need you to put that order in.
Especially if it's a med that you're not comfortable putting in. I feel like that's a big thing for new nurses too, is
Yeah.
there's like a little bit of a timidness to say, "Oh, I can't do that. Please stick up for yourself. No one
Well,
is
and
going
if
to
it
protect your license better than you."
exactly. And if it's like a drip that's titratable or something like that, please have the provider put the order in,
Mhm.
because concentrations can be wrong, different things can be wrong, and they usually have favorites in their list of orders that they are used to using. So this may not be one that you've ever put in. It may not show up on your computer the same with the same ease that it shows up on theirs because they're used to ordering it. And don't let
Yeah.
them tell you that they don't know how to use a computer. I'm sorry, you're a medical doctor. You know how to use a computer.
Yeah.
Just do it.
Or you can also always, if you're unsure too, reach out to your charge nurse, right? Because
Hmm.
I know that there's a couple of times, like when I was charging in the ICU, that I would be way more comfortable putting in something
Yes.
than, someone who's fresh out of nursing school. And that's totally fine. I would never, your charge nurse should never be angry at you for asking for help, by the way. I also want
Absolutely.
to put that out there.
Yeah, they shouldn't be angry about you for asking.
Hmm.
We've talked about this before. It's okay for you to be new. And even if you're not new, even if you're a seasoned nurse and you're like, I just don't know, there's
Yeah,
always
I've
going to
never
be
done this
those.
before.
Yeah, there's always going to be those things where it's like, I've never done this, or it's been 5 years since I've done it. Like when that happens, like that should be a red flag within you of like, hey,
Hmm.
I just need to get help and just make sure that I do this right. Because if we're accurate, we are going to be so much better as nurses. And it might take a little bit more time, but I'd rather take a little bit more time and be safe than do something risky and hurt someone.
Yeah. I would much rather that, because that doesn't feel good when you make mistakes.
No, I
Doesn't
mean,
feel
and
good.
like we'll probably do a whole episode on med errors and different things like that. Nobody wants to have that happen, so we won't get too off in the weeds about that stuff. But we want to help you avoid
Mm-hmm.
that stuff. And the communication part of it is huge. The provider order entry is huge, and it can really help.
Right. So, Nick, I would think I would like to too, because we're talking a lot about documentation. So, kind of like what to chart, right? How do we know? How do we know what to chart and when?
Well, this is going to be, it's going to vary depending on where you work, right? It's going to vary depending on what department you're in and what things that you have in front of you. But this is something that from the time that you're in orientation to the time, the whole time that you work there, that should be getting defined, right? So, one of the things that even at my first job as a CNA in the hospital that I loved was they had a minimum charting requirements for patients for even at the CNA level, they had it for the RN level. It's
Mm-hmm.
like, hey, for our floor, this is what is required of us. And it was, the CNA and the nurse obviously have hugely different charting requirements, which if you're a new nurse or about to be a new nurse and you have ever given your nurse crap about them not doing something that you felt like they should do, I just want you to understand you're about to face it when you get out into the real world and you realize how much charting that they have. And almost every new nurse that
Mm-hmm.
I've talked to is like, holy shit, I had no idea that you guys had to chart so much stuff. And it is drowning. You're like,
It's
well, you only have
it's
five
so much
patients. And they're
stuff.
like, I have 25 patients as CNA. Like,
Yeah.
I don't care. I still have to chart more than you on those five patients
Yeah.
than you have to chart on 25. It is insane. So just know that like this is a common problem. But so like in different floors they have
Yes.
different things. It's like I might have a head to toe assessment that I need to chart every 4 hours, or it might be every shift depending on if you're lower acuity, right? And then you get even lower acuity and you're in like a skilled nursing home and it might be a head to toe assessment like once a week
Mm-hmm.
or whatever, like whatever your facility requires, that's what you need to do. But I would say beyond whatever those minimum charting requirements are, know that it's a minimum. You can always
Mm-hmm.
chart more. If there is something going on with that patient, chart stuff. And I was kind of alarmed because I saw in our comments this last week we were talking about charting and there was somebody talking about how they don't let us have access to write narrative notes and they don't want us to write narrative notes. They only want us to use check boxes. Well, let me tell you something. There is a time and a place, and we will definitely do an episode at some point about
Mm-hmm.
how to interview your employer when you go for an interview. Because when you go to apply for a job, they're not just interviewing you. You are interviewing them to find out
Mm-hmm.
what is the stuff that they tolerate, what is the stuff that they don't tolerate, are they going to keep you safe? And like Courtney said, you're the person who's going to protect your license more than anybody else. So one of those things is what does that medical record look like? Looking back at my first job, when I first started there, they had a pretty crappy medical record. And that medical record did not allow nurses to see the history and physical from the provider. It didn't allow you to read historical notes, which I was like I had been a CNA at a larger hospital system and I had access to all of that as a CNA. So then, like being a nurse and not having that, I'm like, this is so weird. Why do I not have
Honestly.
access to this? And I called it out, and we got a new medical record, and we all of a sudden had access to everything. And it was so much better. I'm like, this is dangerous for me to take care of patients
Yeah.
and not know what's going on with them. So if that's the
I'm
case,
trying
whistle it.
Yeah, I'm trying to even imagine what trying to get through my shift as a nurse that didn't have access to the H&P. That just kind of blew my mind a little bit.
It was insane.
That's actually really crazy. H&P, by the way, for those who don't know, history and physical, it's kind of like the doctor's original like assessment, what they came in for, all of those good things into that facility.
Yeah.
Very important, lots of information. Wow, that's actually crazy.
It's
Yes, please whistle blow any place
yes.
that does that and don't feel
The
bad about it.
H&P is huge because if you've ever like gotten the bill from your provider and they're like, I spent an hour with the patient, you're like, you were in that room for 5 minutes, you're a liar.
Do you
What
know,
they're
can I
talking about is they're talking about the time that they spent thinking about your case and working on your case. It's not just the time that they were actually physically in front of you. It's time that they spent reviewing your imaging, reviewing your labs, ordering all your stuff, putting in your H&P, putting in all this stuff, because they will write out this whole note that is
Mhm.
extensive, and anything that they actually assessed on your body or things that they didn't assess. Like they're not just putting in a bunch of stuff there that they did not actually look at. It's all stuff that they look at when they see you. And I've had patients be like, well, they didn't do this, they didn't inspect that. Well, it probably says in their note that they did not visualize that or whatever, if it's something like that. Or if it's something that they looked at across the room, they'll put in an across the room assessment of what they saw. And that is still good enough. But they do spend a substantial amount of time evaluating patients and documenting on them in order to make sure that they tell the whole picture of what's going on.
Right. Honestly, invaluable information. So with the H&P, right? So let's kind of loop back to narrative notes, because we have just recently actually in our, well, not in the cohort you teach, but in the cohort I teach, right? In the last couple months, we just started talking about narrative notes. So guys, a narrative note sounds kind of scary. What is it? It's literally just a note of what happened in chronological order. They are so important, right? Because it tells a story. The one kind of disclaimer before we get into our charting is when you're writing narrative notes, right? We want you to obviously be objective, right? Narrative notes include objective data, subjective data, kind of like your, we don't want to write too much outside of those two things just because we work in the medical field, right? I'm going to tell you just to take the load off your plate, right? Objective data, subjective data, right?
Exactly.
Don't overdo it. But
and it's not also the place to put in the personal tidbits of like, this is a really nice gentleman. Like, who cares? They can be the biggest jerk or they can be the nicest person.
Yes.
That is not data that needs to be in the medical.
That needs to be in there. And the reason I'm going to really encourage you to write, because I like transparency. The reason I'm going to encourage you to keep it short, sweet, but thorough with your data is because the CARE Act, patients can read them.
Yes. They absolutely can read all of their notes.
Yes, anything you put into a medical record is something that the patient can get their hands on and read it. There is an option usually to like hide a note, right? I know on Epic there's like a little heart icon that you can click, but you have to document in a legal record why you are hiding this note.
Yeah, there has to be a real reason.
And there's criteria that you have to meet. So also keep that in mind, right? When you're doing your documentation, don't write, oh, this person was hard to deal with.
And
right?
That doesn't last forever either. So even in Epic, it does not last forever. And like, if you think that it does, so I had a patient that there was some domestic violence going on, and I was legitimately concerned that if I wrote this in the chart, that this person's significant other was going to read it. And that is actually one of the options of things that is covered. But I got a message from our internal people who audit these charts and audit those reasons, and they said that actually expires after 30 days. So and I don't know if that's everywhere, but I'm just saying, like, that was what on a particular situation. I'm like, man, that could really mess up their life for them.
Yeah.
If they're
really,
significant
really
other.
nuanced.
So it really is, we want to make sure we tell the whole story, but we also want to be sensitive to those things. But you can't just be like, I want to write in here that this guy's a dick. Like, that's not a reason to try and hide it from the patient. And they can't. I was going to say I just had my collarbone broken and repaired. I should go back and look in Epic and see what they wrote about me. See if anybody wrote any trash talk.
Oh my God, that future episode, we're going to go back into our own medical records, see what people write about us.
I only go to the most professional places. So, they probably did not write any trash talk, and they all know me. So
that would, honestly, I would need a lot of therapy after that, I think. I don't know if I would handle that well.
They're like, subject is a 40-year-old man with the body of a hairless cat. I don't know.
Yeah, I don't know. Something that would just ruin my day.
Oh my God.
Anyway, so we have other different kinds of charting, right? So a big one is your narrative notes, right? That's something that we can use. Another big one is this idea of charting by exception. So when you're charting, usually when you pull up whatever EHR you're using, it'll separate it by system. And so you can go in and there's your option to put like within defined limits, within normal limits, however you want to do it. But one of my personal favorite boxes is the define your baseline box. So, and say you have a patient who's a quad. That's really like extreme, but we're going to go with quad just to make a
Sure.
point. And say it's like a complete quad. So we have no feeling except the phantom pain, no movement. You could, if you really wanted to, go in and put that they're not within a typical individual's defined limits. And that would make you have to go through and like put they can't move, can't move, can't move, can't move, no sensation, no sensation, no sensation, no sensation. As you just heard, a little bit of a mouthful, right? It's a lot to chart. It's a lot to read, especially if you're going through and you're doing chart reviews or say, you're having a really busy night. So what we can actually do instead is put within defined limits, within normal limits, right? Because you're not charting based off of a typical person. Because if you have a baseline box, you can actually define that baseline. So you can
Yes.
say, patient has complete quadriplegia, and then put within normal limits. And that's still charting the same thing, right? It's just making your life like a little bit easier.
It's that same thing that we talk about with the
Yeah.
if I've got a 90-year-old patient, I don't need to talk about what happened with their 12 when they were 12. Like if this is
Yeah.
an old injury, chronic, stable injury
Hmm.
or whatever, and in this case, it did establish a new baseline. They went from being somebody who was ambulatory, but I don't need to write that they're non-ambulatory now
Hmm.
every
Because
time
it's
because
right now.
it's right now their baseline is non-ambulatory. That's not an acute change. So if we
Hmm.
were charting by exception, it would be like, and there was actually a change, and they went from being in this hospitalization, they went from
Yeah.
walking to now they're not. Sure, chart that, but like if it's old, it's old.
You don't
That
have to
is
worry about it.
baseline. That is
And
baseline.
it makes your life so much easier. You know what
Much
I
much
mean?
faster.
Much,
And
much
now,
faster, much, much more
obviously, if
efficient.
you've got somebody who's never been to your facility before, you still have to establish that baseline. And so that might be is this normal for them? That is a huge question that is so important to ask people with neurological status or breathing status. If you've got somebody who's got a COPD or that their oxygen saturations are always at 88%, and maybe they've never been to your facility before, when you ask the question, hey, what do you have a history of COPD? Yes, I do. Okay, what's your normal oxygen level live at? Like, where do you stay at on a regular basis? Oh, well, I'm on 2 liters of oxygen and I sat between 88 and 92. Boom, done. Put that in as your baseline. You
Hmm.
establish that baseline, and now all of a sudden it doesn't look like you're charting that this patient is at 88% and this should be a cause for alarm. You've just established that that baseline exists and that's normal for this patient, and then that's okay.
Yeah. Yeah. Right. And I love it. It makes your life so much easier, especially because like charting's hard. You're always learning something about charting. You are always learning something about any type of documentation, like even SBAR. Like you're always slowly like funneling it into being more efficient for you.
Now, when we talk about efficiency, though, I do want to make sure that we clarify something. A big pet peeve of mine is seeing people copycat chart. Copycat charting, if you're just copying and pasting what somebody else did, I'm sorry, that's not acceptable. I'm sorry, it's
It's not.
not. It's not acceptable. That's not good nursing. And things that we see where this happens that gets picked up on by people is they'll be charting like pedal pulse on somebody who doesn't have a lower extremity, and like then all of a
I
sudden
used to work
somebody
ortho
realizes
trauma,
it, and you're like, oh my gosh, how did
and
10
that
people chart
happens
this
a
in a
lot.
row that this person has a 2+ pitting edema on the leg that doesn't exist, or they have
Hmm.
a palpable pulse on a leg that doesn't exist. How did that happen? And it's because we get into this like copycat charting mentality. But before you come at me in the comments and be like, well, we do that to speed things up. Okay, fine. But I also want you to understand that if you're wondering why your provider doesn't trust you when you offer a recommendation, it's probably because you do stuff like this. Just
Yeah.
saying, like,
I
quit cutting
I would like to
corners.
point out though that because they actually touched on this when I was in nursing school like 10 years ago, and do not copy other people's charts, right? But to me it is acceptable if you come in and you do your very first head to toe. You put it in, you chart it. It is okay to do your own. I will say that. Like, do
Sure.
your own, go through, but you still have to read every box, guys. It doesn't really make it faster other than you're just not clicking buttons. But, like,
It does
I don't
still
know,
have to
to
match
me,
the patient's
it
clinical
does still
picture for
have to
today.
match. Yeah. but you can copy your own. But you really should get into the habit of going in and doing that full head to toe, right? And charting it, hopefully in real time. And then that is okay. But you still have to go through and review it. There's
Exactly.
no situation where it's okay, even just to copy your own and put it in and hit sign. That's never okay.
For me, though, Courtney, this is a reason why I have a hard time, like with bedside report. If I'm giving report to somebody and they're like asking me about all the different assessments, well, how did this sound and what was this? I'm kind of like, grab your own stethoscope and go and check, because like I've documented mine. You can see what I documented, but I'm
Mhm.
not trying to fill out your assessment for you. And maybe that's wrong. You know what I mean? Like but I'm going to give report by exception too in a lot of ways as well. And I'm going to tell you, this is what I notice is wrong. I'm going to give you the overall picture. But at the same time, I'm not trying to make it to where you can just write down everything I said and then just chart that and not do your assessment. You
Yeah.
need to go do your assessment. And part of being a good nurse is getting in and doing your assessments and seeing the things change
Hmm.
as they evolve and being able to recognize those changes. I think that that is so important in your overall care.
Yeah. And not everyone does it. It's so funny because I remember I was actually sitting for a patient one time. Um, and like this nurse didn't even give, this is so scandalous. This nurse like didn't even give the patient's meds because they were having like a really busy night. And so I was like, it's fine. I can give the meds. Like I was sitting on a med surge floor and I'm like, it's a freaking Tylenol and like starting a Zosyn.
So they just
It's
never went in
whatever.
and saw the patient.
They never went in and saw
Oh
the
my God.
patient. And I remember, dude, it
That's
was like
wild.
2 a.m. And I was like, this nurse is like never come into this room. And I looked, like I pulled up the chart because I'm nosy. I'm gonna pull up the chart. I
Sure.
pulled up the
You're
chart
taking care of
and
them.
they had like actually documented that this like full assessment. And that nurse had never been in that room except for bedside report. And obviously, like, we
That's
don't do our
wild.
assessment during bedside report. Right? I was like,
That's wild.
this is actually crazy. Like, if
Yeah.
if I hadn't been a nurse, right? Because she didn't even go in to give meds. It was wild. One
Well,
of the
and so
craziest
you
things I've ever
wonder if
seen.
something like
Like,
that
so
happens, like, is it because you're a nurse that they didn't go in? They're
I
like,
think so.
she'll let me know.
Because I
So
was an ICU nurse, so they were probably like,
yeah,
oh, well, if something's weird, like there, but
you're gonna
guys,
tell
I
me.
was sitting, I was not the patient's nurse. I was
Yeah.
sitting as a sitter for the patient. Like I didn't have any of my shit that I would normally have, like going into that room, to care
Not
for
to
a
mention
patient.
it's not your floor. You're not at your home
Yeah.
base.
I'm not,
Yeah, I
it
mean,
was wild.
that
One
is
of the
really
craziest
wild.
things that's ever
Like,
happened to me.
here's the thing. I just get too much anxiety that somebody's gonna die in the middle of the night and
Hmm.
I'm not gonna notice it. You know what I mean? Like,
Yeah.
I'm gonna
That
round on my
happens actually
patients.
a lot.
Yeah, I'm gonna round on my patients. I'm gonna make sure that stuff is good. I'm going to make sure that I see them and I watch them breathing. Which, here's another thing I want to make sure that we point out with charting. Okay, we only document things that actually happened. We only document things that we actually did. We don't chart future tense. So I hear a lot of people saying, and I see a lot of people documenting this, they'll write their narrative note and then at the end they finish it off with a good old fashioned will continue to
We'll continue
monitor.
to monitor. Yes, don't
Like,
do
we
that.
are not going to continue to monitor, as far as we're not going to record that in the chart. And here's why. What happens if something happens after you write that and you never get back to continue to monitor them in the chart and the patient has a demise? Okay. If that happens, now you've said that you were going to go back, and a lawyer who's worth their salt is going to say,
Hmm.
well, did you go back? Did you go back and do that? I mean, you said that you were going to, so when did you do that? Don't put, I'll be
Yeah.
back at 7 a.m. to do this. Don't do that. You are
Because you don't
writing
know.
yourself into a corner. You don't know what's going to happen. What if you get sick and you have to go home and somebody else picks up your patients and something
Hmm.
happens to that patient? And now you've said, I'll be back at 7 and you are not back at 7. Don't put constraints like that in your charting. You're writing yourself into a corner. You're putting yourself at risk of absorbing something legally that you don't want to absorb. So,
Nick, did you ever watch Better Call Saul? Did you
but
ever
yeah,
watch that? I
that's like one of
That's
my favorite
actually
shows.
the
So,
yes, it's
Breaking
amazing.
Bad is my favorite show of all time.
Breaking
Better Call
Bad, Better
Saul.
Call Saul, shameless plug if you haven't watched it. watch it.
Are
It's
you plugging
amazing.
Shameless as well? Because that's also a good one.
I got to like season 5 of Shameless, and then I was kind of like, I don't
I'm
really
not white
care.
trash enough
Like
to watch
like
it. Like,
what's
I
going
loved it,
on?
but I've
I did watch the first couple episodes, yes, but I actually use Better Call Saul as like my example when I'm like teaching documentation. I'm like, pretend that Saul Goodman is going to go in and look through your chart,
for real.
because lawyers are not your friends when they are on the opposing side, right? Like, that's their job, and we can't fault them for doing their job. But like, going back to this idea of you are the only person who is going to protect your license the best, it's
Yes.
you. And so pretend like Saul Goodman is gonna go look through your chart and chart like that, and dude, you'll be set.
Well, and the thing is that a subpoena just never comes in quickly. Like, it's going to be
Mm-hmm.
years before that happens. So whatever you write in your chart today, that's what's going to be there in 3 years when they subpoena you. And let
Right.
me tell you, that is anxiety inducing when all of a sudden you're like, whoa, I got all this documentation
Yeah, because you got
for this
subpoenaed,
chart. And
right?
yeah, I got subpoenaed, and it was like, that messed with my head, man. I'm like, did I write the right things? Have I said enough? But you can't go back and change it, right? You can't even
Mm-mm.
modify it the next day. You get to modify it in real time the day that you're there. And that's just how it
Yeah.
is. So, like, if it's this legal document that you're writing, you want to appear professional, you want to appear knowledgeable, you want all your ducks to be in a row, you want your stuff to be standard of practice, and you want stuff to follow policy and procedure
Mm-hmm.
for your facility. Because guess what? If you get subpoenaed, you're going to be held to all of those standards. And if you still work for that facility, great. If you don't, that's also okay, because malpractice insurance should cover you from when you were working there.
Mm-hmm.
However, the recommendation is to have your own malpractice insurance. It's not that expensive. Totally go and get some. Cover yourself, because you just never know.
Yeah.
But I definitely, like, when I got subpoenaed for the ER, yeah, I was kind of like, oh crap, should I have this? I did talk with my former employer. They were my former employer at that time too. And they said, no, you're covered from through the malpractice insurance from everything
That's
that was
good.
going on at that time. You are covered. So just go and do what you need to do, and it's going to be okay. But yeah, I'm just saying, leave no doubt, right? Like, make sure that your charting is good, and that's going to be huge. This round of
And
ER-ICU showdown. Show love
yeah,
for the ICU
and
in the comments, damn it.
please show love for the ICU, damn it. We're good people. We're just type A and slightly autistic.
All right, so now, guys, what we're going to do is we're going to talk a little bit ER versus ICU, just because this is so fun, because we think similarly but different, and it's
So
great. And the thing I love about nursing is that there's room for all of us at the table. We can all be friends. We can all kind of have a little bit of frustrations with little things that each other does, but at the end of the day, we are part of the same team. So we want to talk about SBAR communication and how it looks different depending on where you're at in the hospital or whatever type of care facility that you're at.
yeah. And before we get started, I just want to put this out. I need some ICU love in these comments, cuz listen, we're not bad people, okay? Some of y'all came for me in the comments about those fucking lines being untangled.
But they were
We're
untangled, take it.
we are good people. We're just a little type A and a little autistic,
That's
okay?
right.
Give us grace. But if you're patient, well, we're going to get into this later. Just I need ICU love in the comments, please.
You heard her. ICU love in the comments, ER
Yeah.
love in the comments. Let's get this party started.
Yeah.
Let's have a little bit of discourse, and go
The
ahead, get it
ICU
off your
nurses,
chest.
yeah, the ICU nurses aren't in the comments because we're too busy untangling fucking lines to be on
Yeah,
TikToks.
they're too busy correcting their punctuation
Yeah.
and grammar.
Yeah.
ER nurses, we're just unhinged. We're like, oh man, I'm
So
gonna
on
throw this
brand.
out there. I don't care if there's 20 typos. All right, did I write it down? Did
So
they
on
die?
brand.
Did they die?
You're like that meme from The Hangover where it's like, but did I is that The Hangover?
Yeah, but
Where
did
it's
you
like,
die?
but did you die?
Yeah. Hey, it's a very common saying in the ER. All right. So we've been kind of brainstorming about this of how do we want to present this to you guys and what's going to be a great way to do this. And so many of you are in school right now, and some of you might be for the first time. Some of you might be going back for more education. But what works best often is a little bit of role play. So, what Courtney and I have done is we've actually put together an entire patient chart.
Yeah.
And
It's going to be
we're
so
going
good.
to role play as I'm going to be the ER nurse. She's going to be the ICU nurse. And I'm going to call her and give her report. And I just want you to know this, it might be a little bit of an exaggeration. For some, it is definitely an exaggeration for me because although I am
Yeah.
ER through and through, I actually give a pretty solid report because I know that it matters. And
Yeah.
you can pick up any of these things and get better with them over time. So please don't feel like that, like, if you're in the ER, that means that your report has to suck ass, or that if you're in the ICU, that you have to be pissed off at everything that the ER says.
Yeah.
So remember,
Because
we're part of
I'm in the
the
same
same
boat.
team. So
I am also not like a super type A ICU nurse. I usually just went with the flow. So role play, guys.
all right, here we go. So hey, Courtney, it's Nick from the ER. How you doing?
I'm doing good. What you got for me?
Yeah, this guy. His name's Jason Miller, 24-year-old, type 1 diabetic. He's here for DK. Pretty classic on me, honestly. Yeah, he came in a little bit earlier today, complaining of nausea, vomiting, a little bit of abdominal pain. He said he really hasn't been taking his insulin because he's been sick with a cold or something. I don't really know what that is
Hmm.
about. He's had DKA before, I think once. Otherwise, pretty healthy. No allergies. He's a full code. Vitals are better than when he came in. He was in the 130s for heart rate, now closer to 110 ish. BP was soft, but came after fluids. Last one's around 108 over 60s. He's still breathing kind of deep and fast, kind of Kuzmal-ish, but not as bad before. He's sleepy, but he wakes up and answers questions just a little slow, kind of groggy. Sugar was 500 something when he came in. Now it's mid 300s. His gap was high, around mid 20s, bicarb low. He started in single digits and now he's about 10. Potassium started high at 5.8, but now it's in the fours. He's got 2 liters of normal saline and is on an insulin drip at zero point 0.1 per kilo. Haven't had to adjust it much. No potassium's on board yet. We held off because it was high, but you'll probably need to start that. Labs are trending. BMPs every couple of hours. It's all in there. He's got good IV access. He's got two 18 gauge IVs. They're both working, bilateral ACs. He hasn't thrown up recently. Urine output was good. So yeah, just continue DKA protocol, fluids, potassium, insulin. You'll probably need to add some dextrose soon. Honestly, he looks way better than when he came in. Pretty straightforward. Anything else you need?
Yeah, actually, a lot. So actual numbers, please, please. With the ish, do we have real numbers or do we just have
Yeah,
the
it's on the
ish?
chart. Didn't you read
Are
the chart?
you are you looking?
No, I
Okay.
got a code coming in 5 minutes. So I haven't had a chance to
Okay.
look. I'm just trying to clear this bed out.
So heart rate are is where right now? Blood pressure. When did you even take that blood pressure?
I got it set to cycle every 15. His heart rate,
Okay.
like 110s right now.
Okay.
He was 130s. Um,
Okay. So I know that you're giving me the dose of the insulin, but like what's it actually running at? Where's it going?
yeah, I mean it's a titratable dose on that, and so I just
Yeah.
started it, and I haven't titrated it yet.
Yeah,
Like I
well
said,
we touched on that with the this idea of DKA protocol. So can you like go look at your pump and tell me what is that?
yeah.
Or are you in front of a computer? Can you like tell
No, I'm
me
kind of walking around the
actual
hallway.
labs?
I'm kind of walking around the hallway right now.
Okay, okay.
I got another patient coming in. Like I said, I got code blue and 5. I've got a nurse that's going to take him over to you. They're on the elevator right now.
Oh, okay. So thanks for letting me know that before you left the room. So the potassium, did you hang it or no?
No, like I said, it was still in the fours, so they didn't put that in yet. They said it'd be on the
Okay,
inpatient
well,
orders.
so if he's still in the fours though, they ordered potassium for a reason. So when did they even order the potassium then?
I think it's still pending pharmacy review, so that's why I haven't hung it.
Really? Because I'm looking in the chart right now and it's not, and it was
So it
ordered
must be in
3
his
hours
ICU
ago.
admit orders.
No, it's not. It was definitely ordered by your doc. I already looked. So you're telling me you didn't hang the
No, not
potassium?
yet.
Okay,
Definitely did not.
so got it. So the potassium that was ordered 3.5 hours ago by your doctor was not given. Okay, sounds good. And then you said he was a little slow-ish. I mean, is he how many times is he alert and oriented? Like what what do you mean? He's a little slow.
Just a little confused. So, he's still alert and oriented, maybe times three.
So he's confused, but so what is he alert and oriented to then?
He
Because
knows who he
level.
is. He knows where he's at.
Okay. So
But
self.
like he knows he's
Wait.
in the hospital, but he's just kind of dazed.
He's kind of dazed. Okay. All right. That makes sense. So I love that you just told me alert and oriented times three, but also confused. So that sounds great. Okay. Was he on telemonitoring? How did his EKG look? Did you
Yeah,
even get an
I mean,
EKG?
yeah, we did. Oh, for sure. It's in the packet coming up to you.
Yeah,
It
I know.
should be
I
on
already
the
saw. I already
packet.
saw it in the chart.
Well, if you knew, why'd you ask?
So it looked good, just so that you had to say that you didn't know. Sorry. Okay. How did his telly look? Did you get an EKG or what did that look like? Was
Yeah,
he on
it's on the
telly?
chart there. His
Yeah.
T waves are a little tall, because his K
Okay.
was high.
So what was like his QRS? What caliper was his T wave at?
Oh, geez, I don't remember.
Well, that's okay. I already looked at it in the chart. You're good.
If you knew, why'd you ask?
So that you had to say that you didn't know. So how's his gap?
High.
High.
Well, it's
Okay. So
improved.
we're following DK protocol, but we don't know what the gap is. Okay, sounds good. And then Kuzmal-ish. What does that mean? Is he
Fast.
Kuzmal breathing or is he not?
He
Oh,
is.
so he's just tachypnic. Okay. Sounds good. So we're dealing with
Well,
some
I mean, he's
tachypnea.
got the
Okay.
ketones all over his breath. You walk in the room and it smells like a fruit factory. So
Okay, thanks for telling me that earlier. I really
yeah,
appreciate all of the information. Okay, Nick. Well, I think that this is all that I need. I'm
awesome.
just gonna
Thank
look
you.
through the chart and get
Thank you
everything
for
up.
the supportive teamwork.
Okay. All right. Thanks, Nick. Have the day you deserve.
All in all, what do we think of that report? Is it accurate? Is it ridiculous? Is it over the top? Maybe a little bit of all of the above. But all in all, this is a similarity to how sometimes report goes down from ER to ICU. And it is a reason why we see ER nurses who are afraid to call and give report. And we
Mm-hmm.
see ICU nurses who are like, ugh, freaking ER. God dang it. Why didn't they do this? Why didn't they do that? Ultimately, what we come away with is that the report here, was it unsafe? Not necessarily,
Mm-hmm.
but it also wasn't ICU ready.
Yeah. What we're seeing, honestly, is just a clash of primary job responsibilities, right? Like in
And
the
personality
ED,
conflict too. Like just
yeah, it's so
we all have
funny
different
because
priorities of what's important to
yeah,
us.
like as you go through nursing school, you kind of see like these little nursing personalities come out, and you're like,
Mm,
oh, I have an idea of like where you're gonna end up when you graduate. But in all reality, guys, none of them were inherently wrong, right?
right.
Like the ICU job responsibilities are so much different. And that's why we require like a lot more specifics, right? And a lot more information. But the ED, you guys are so like, I can't work the ED. I am the first person to say that. I don't want to work the ED. Like, I can't handle that kind of smoke. You know what I mean? Like, I
Absolutely.
just want
And
a
I
nice,
can't
controlled
handle
chaos.
the ICU from the standpoint of like I remember during COVID we actually cross trained to the ICU so for surge
Hmm.
staffing, and the ICU cross trained to the ED, and we had some tele nurses that cross trained to the ED, and it's so funny because the different personalities that coming out, but I feel like there's like this shared respect, this mutual respect that happens when we do
Hmm.
that. So if you're a nurse leader out there and you have say in these kind of things, put people through some cross training. It's not a bad thing for them. It's okay for them to gain empathy for each other. So I
Right.
think that in this situation, what we have is we have this ER nurse who's like clearly juggling multiple patients, maybe five, depending on where you're at, right? If you're like a super high acuity ER, if you've got more stable patients, but you still have a lot of patients to deal with, or if you have a bunch of unstable patients, like it's just too much. And you're focused on stabilization and moving forward, focused on
Hmm.
getting things the way that they need to be and moving on. But in the ICU, you guys live in the details. It's like, I need to know all the little stuff because this critical patient that's coming into me, for one, are they going to be a one to one patient, or are they going to be somebody that I'm going to be having another patient that's also just as sick as them or more? And that's a lot to do as well. So it's different ways of thinking, different things that need to happen, different interventions to get them to that point of step down. So as an ER nurse, we can make our report better in a way that's going to be helpful for our fellow nurse to be able to feel comfortable with their job.
Yes, I do.
But as for the ICU, you guys live in the details. Like all those little things, they matter so much and help make it to where your shift goes along smoothly and everything functions the way it ought to.
Right. And just so everyone knows, of course, there's always kind of like this stereotype of ICU versus ED. Guys, there is a mutual respect there, right? We couldn't
Absolutely.
do what we do with our admits without ED nurses getting there and just being badass and like stabilizing patients. I kind of feel like being able just to hand off, right, your ED patient to an ICU nurse, I would imagine, and correct me if I'm wrong, Nick, that there's probably a little bit of relief there too, right? That they're not
100%.
needing those ICU level and like interventions the whole time.
100%. And I think that some of the issues come, especially if you're a newer nurse in the critical situations, you're like, once they're on pressors, once they're on titratable drugs, like, and you're one-on-one with that patient, you're kind of like, okay, this patient is really sick. We've identified that they need intensive care, and I'm not an intensive care unit nurse. And so you're having to operate in that intensive care level capacity. And it's fun for a while. And then you're kind of like, okay, I'm ready to give
Mhm.
this away and go back to my fast paced craziness that is like the chaos that I'm used to and the chaos that I enjoy most. But when it becomes something where it's like, okay, well, they've been down here as a critical patient for hours and this is hard. And I don't, maybe we, and ER physicians don't always put in all the ICU orders. So like that is a true barrier where sometimes you'll have signed and held orders that they're all ready to go in that for the ICU, but they tell us not to activate those in the ER unless they're there for a prolonged period of time. And nobody wants to get into it because, like, well, now I have to do all this stuff and that's a lot of freaking work.
It's a
And you
lot
may
of work.
still have
Yeah.
other patients that you're responsible that are ER patients. So I think that we just gain that mutual respect and understanding when we know kind of
Mhm.
what the other person's going through. So for me, I became a better ER nurse when I started really looking at what does the ICU need from me and what are they constantly asking me. So I try to know those things. I try to be better about that. And that's why I tell you that report is fictitious. That's a whole
Yes.
I give a better report than that because I give real
Yeah.
numbers every time. And I'm like, nope, this is what the gap is. This is what it was. This is how we closed it. This is, you know, these are the orders that they said they're putting in. Maybe they haven't put them in yet. And that happens too. And so it's knowing though what's going to make that ICU feel more comfortable and feel supported and making sure that they have what they need when I send that patient to them. Because otherwise, they're feeling like, okay, I just got this catastrophe dropped in my lap, and I don't have everything that I need, and I want to have everything I need to be successful.
Yeah. And that was very fictitious because I will usually go in and just familiarize myself so that that way, whatever information that I'm given, right, from the ED, it's just like added stuff
Hmm.
because I like to just have a pretty good idea about my patient. But perks of working right inpatient is that sometimes your admits, like, they don't come right away, right? And so you can kind of sit down
I would
and look
love
up
to
your
show
stuff
you the
some of the
difference,
time.
though,
But
of what an ER-to-ER nurse report looks like in that
I would
situation.
love to see that because I will tell you right now, an ICU to ICU report would take like probably about 15 minutes on this
So
one
do you want to hear it?
patient.
Because I can give it
I
to
would
you
love to
right
hear it.
now.
Yeah.
Okay, so
Yeah.
here's how it's going to be, and it may be a little bit more than this, and I'm just shooting from the hip here. Let me get that page back open real quick. So, hey, Courtney, this I've got Jason Miller, 24-year-old type 1 diabetic here for DKA. Pretty classic presentation, nausea, vomiting, abdominal pain. He stopped taking his insulin because he's been sick with a cold or something. He's had DKA before and been hospitalized for it. Otherwise, pretty healthy, no allergies, full code. When he came in, he was pretty tachycardic, up in the 130s. Now down to about 110. EP was soft, but came up with fluids. We're currently sitting like um, low 100s up to 110 max for systolic BPs. So still kind of playing with that with fluids and the insulin drip. He's still breathing kind of fast, Kuzmal's, but not bad as bad as before. Definitely has that smell of ketones. Um, he's a little sleepy, but wakes up, answers questions, A&O times 4, but just kind of a little bit of lethargy. Sugar was 500s. Now it's 300s. They're going to want to know about the gap. I'm still waiting on that to come back from the lab. It's not back yet. Anyway, he's got 2 lines in. They both work. And we're getting ready for transfer to ICU. You need anything else? And literally that's a no from every ER nurse. No, I'm serious. The rest is in the chart. The rest is in the chart. And that is the way that it goes. I'm telling you, the rest is in the chart.
So I'm going to let you know.
I wrote a good narrative note that you can read.
I would actually have a mental breakdown if I got that as a report.
But here's the thing.
Yeah, I love it though.
We're so used to everybody who comes into us doesn't have a label on them of what's wrong with them. So what am I going to do? I'm going to go read through all the chart. I'm going to see all of this stuff. Like, so this is another mind-blowing thing for most ICU nurses. Like, you have your brain that you like to write down everything, and you have your particular way of how you like to write stuff.
Can I just show that? I actually did write down a report.
Yes. Like, that's what I'm saying. Yeah. So you have this, and what I'm telling you is that report that I just gave, that other nurse that's coming on shift is standing there with nothing to write, and they're listening. We don't write stuff down. We put it in the chart. Because here's the thing. But here's the thing. How many patients do you see in a day? On a good day, like maybe. On a good day, 2, right? On a good day, 2. Sometimes so on a good day for me, one-to-one. On a good day for me, I see 25 patients in that day.
Listen,
and that's from start to finish. That's from start to finish. Man. If I'm having to write down a brain on everybody, it takes so much time to write stuff down and then write it down again in the chart. So I write everything in the chart. When I go in and I assess a patient, I document at the bedside. So my narrative note is in before I leave the room. Yeah. I'm asking all my questions at the bedside. I'm clicking all my check boxes. I'm writing a narrative note. And that narrative note is something that I can give a report off of. So if you've read my chart, you've also read my narrative note. So when you're like, I'm giving report and you're like, you're just reading your narrative note off to me. I'm like, yes, because I have 5 other patients that I'm thinking about. So you know what I'm saying? So it's like, this is an efficiency thing from the ER standpoint. And it's just, it is what it has to be, you know?
Mm-hmm. Yeah, no, that's why I have mad respect for y'all. Because honestly, like even the couple times, because I used to cover tele at my old job, and even the report there, I'm like, it's almost like it short circuits my brain. I'm like, how can you care for this patient if you don't know absolutely
Have you ever watched the report at nursing homes? Have you ever watched that?
I used to work at a nursing
They're like, this is John, he's fine. This is John, he's fine. This is Jack, he's fine. Like, I'm like, what the hell is that? That's not a report.
That's literally how
they're fine.
Report.
Like,
and so
okay.
It like, dude, it's crazy because that's how I started, right? Like I started out in a nursing home. And so like, that's how we used to give report because we were so familiar, like with every single patient. And so it's kind of cool to see like this development of like what I'm comfortable with, right? Like even getting those 4 tele patients, 4 or 5 tele patients, I was like, how am I supposed to safely care for this patient if I don't? And everyone's like, well, they're stable. And I'm like, but they could very well not be stable at some point. And then how am I supposed to care for them? So like, honestly, mad respect to you guys because my psyche is unable to like be okay with that. But that's why we have ICU nurses.
Yeah, but that's just it though, is like, here's the thing. If I walk into the department and I don't get report on, like, say that you're tied up with somebody, I've had days where like somebody's in with somebody who's super sick and that shift change is happening and it's been 30 minutes and nobody's come out or whatever.
Yeah.
I'm like, I've already read all their charts. I know what's going on with all of them and I can see what orders are due, what things need to happen. And so like I go find them in a room and I'm like, hey, and they're like, I'm just finishing up cathing or doing something, right? Something's going on. And I'm like, do you want to give me a report on this patient that you're with? I've already read all the other charts. And so like we might just skip report because I already read the charts. I might have even gone and seen those patients already. And I'm going to go assess them as soon as I see them. I'm not going to
Yeah.
wait. You know what I'm saying? Like I'm
Yeah.
not just relying off of what they told me, because a lot could have changed in that 30 minutes. Somebody could have decomped and gone downhill. I'm just going to go see them. So like, it's that
Yeah.
benefit of the doubt of like, I just trust that they're doing everything that they're supposed to be doing, and I'm just going to go and take care of stuff.
Yeah. Totally different worlds, man.
It
Mad
really is.
respect to you, but totally different worlds, because like I'm gonna have to talk about this information in therapy this week.
Sorry to scar
So
you.
yeah, that's actually gonna give me some
I
type of
think that the
trauma
two
thinking
18
about that.
gauges in the ACs is probably one of the most scarring things I said, huh?
Like it being in the AC, like, no, don't put any, like, but I feel like that's an impatient thing, because like
Yeah.
we love, like, impatient, we don't like the ACs, but that's just because they're like there, you know what I mean?
Well, and
But for you
if you're
guys, I
somebody who works
understand.
in if you're somebody who works in med surge, you probably hate the ACs. If you're somebody who works in tele, you
Yeah.
hate the ACs. If you're somebody who works in ICU, definitely hate the ACs.
Yeah.
Here's why we use the AC. Okay, for one, it's
It's
easy
because it's
access.
easiest, right?
But
It's easiest
for it's not just
access.
that though. So a lot of times we have patients come in that they need a pulmonary embolism rule out, and they need to have a CT angio. And when they
Mm-hmm.
have a CT angio, radiology actually tells us that they want that IV placed in the AC or higher, and it needs to be at least a 20 gauge in order to handle the flow. Because I don't know if you've ever watched the flow of fluid when they put in that
Mm-hmm.
contrast. It goes
Yes,
in
because
super fast. It's
we
like
have to
a
go with our
volume
patients.
bolus like that big, and it's in like 5 seconds. It's not like a long, a drawn out thing. It pushes in
Mm-hmm.
so much. So if you don't have a good vein, and if that fluid extravasates and gets outside of the vessel, it can actually cause tissue death all around it. So if you do it in somebody's hand, they could lose functionality of their hand for the rest of their life, or their forearm. But
Yeah.
an AC is less likely to blow out. They're big veins, they can handle a lot. So that's why we do them. It's not just because we're like, I can only hit a vein in the AC. In fact,
Yeah.
for me, that's another practice change that happened for me, is that as I like got to know my ICU nurses better and their needs, I started dropping ultrasound IVs in their upper forearm, like, in
Yes.
places that are going to be good, long acting, IV access for them. And I put a long 20 in, or I put a long 18 in,
Mm-hmm.
so that way they have a long catheter that's good. It's something that's going to last. If they take care of it, that'll last their entire stay. And obviously, if they need central line or something like that, we do that. But ultimately, I'm just putting in a long catheter in a place that's going to be not positional for that nurse, because I'm trying to set them up for success. If they have multiple drips and they have non-compatible stuff, and maybe they are hard stick, I might put in a twin cath, so they have a 20 gauge and a 22 lumen on just that one device.
Mm-hmm.
It's like a poor man's central line that's not really a central line. It's still a peripheral
Yeah.
IV. But
But
I'll
it's
put
something.
something, yeah, I'll put something like that in. And like, seriously, when I changed that about my practice of like trying to think about that next department, all of a sudden I had mad respect from the ICU of like, hey, thank you for
Mm-hmm.
doing that. Like, that's really helpful, So, and it's not that they can't put their own line in, but it's just nice to not have to poke the patient again. So, and the patients
Mm-hmm.
prefer it. If they have good access, it's going to last a long time.
Right.
Next, what we have up for you is a new segment that we're going to call the ICU Spectrum. So basically, this is a period of time where I'm going to present Courtney with a bunch of different scenarios, and she is going to actually graph for us in the most type A way that we possibly can, an X and Y plotting map to determine where these things line up on here. I think it's going to be great fun. So, without further ado, Courtney, if you would share your screen. So, what do we have going on here on this, Courtney?
Okay, so in very ICU fashion, I made a little graph here. So Nick has pre-prepared some ICU like ick or just ICU scenarios, and I'm gonna plot them on this graph
And we're going
because
to
a lot
see
of
where
y'all
we end
came for
up.
me. Yes, because a lot of people came for me in the comments about the freaking lines. No ICU nurse is mad about the lines. We're just silently judging,
Yeah,
but
yeah.
we're not actually doing anything about it. So now we're gonna learn. We're
So,
gonna
we're going to
learn
find
because
out how mad
this is a
or annoyed you
spectrum.
are versus
Yes.
tolerable and happy.
Yes. And
It's
it's
like the
gonna be
crazy
great.
hot matrix for
It's gonna
dating,
be, yeah. And
but
I
for
have no idea
ICU.
what Nick wrote down.
Yes,
So
so these are
this
all
is,
fresh. Courtney has no idea. So we're going to see
yeah.
some real time reactions and real time feedback here.
Okay.
All right, so here we go. First one. I'm going to say, as in report, I'm going to tell you they've been stable all day.
Hmm. That does fall slightly on the annoyed spectrum, but they've been slightly stable all day. You know what? That's going to fall like right in between annoyed and tolerable, because if they're that stable, I hate the word stable as an ICU nurse, because no one coming to our floor is ever stable. They're just acceptable. But I'm not really like mad about it. That's a pretty good like I'm gonna put it like here. There's worse things that you could say to me. It's
Okay.
relatively tolerable, relatively happy.
Okay. How
Worst things you could
about
say.
calls report early just to give a heads up?
Oh, I love. Well, did you vote me,
Yeah,
or did you just cold call
I
me?
just cold called you and said, hey,
Okay, okay.
just to give you a
I
heads up.
mean,
They're not coming up yet.
oh, okay. I would be slightly annoyed at the cold call. Oh no, if you gave me a heads up, I do love that actually.
Okay. I was gonna say, man, I'm like calling you, giving you advance notice, and
Yeah, no, if you're
you're
calling me to
pissed.
give a heads up, I'm gonna, but like slight, like it's like here. It's not 100% tolerable just because
Okay.
don't cold call me, but that may be a personal issue. Not really
Okay.
like,
All right, next one. I sent the patient up right before shift change.
okay, what's wrong? Oh, well, that depends too. Give me a diagnosis. What's the diagnosis on the patient?
Um,
Here's an
hmm.
answer from
Oh, what's the patient's diagnosis? Is it like a postcode, or is it
No,
like
we're gonna say this is like it's just sepsis. We'll just call it sepsis.
just sepsis? Do they have a central
Shocky.
line? Do they have a
No,
central line?
no,
Do they need a central line? Are they on
probably.
pressers? God damn it.
You're asking too many questions. I got one statement here.
You got That's also a difference between ICU and ED. Okay, yeah, I'm pretty how long has the patient been in the ED? How long have they have transfer orders?
I don't know. You got to go off of what you know.
Okay. I'm gonna put that, let's see, right
Right
before shift
before shift
change.
change.
God, that's annoying. Cause then I gotta stay later because I have to help my friends get set up. I'm gonna put that's gonna be like here. I'm gonna be pretty annoyed with that. No fly zones. Those are a real thing and I love them.
Okay. So now we're going to say that I'm sending you a patient with one IV and it's questionable.
What's running through the IV?
I don't know. Just they have one. They're coming to you. They're in the ICU, so they're going to have something, right?
Annoying. Okay. I'm gonna assume it's a 22, so I'm gonna put that there. We're not looking good with that
No, we're
one.
not. Okay, let's see here. What do we got? We're gonna hang on to this patient and intubate them before we send them upstairs.
Chef's kiss. I'm like here. Thank you. Thank you for intubating them first,
Yeah,
not
you're
sending me
welcome.
someone in respiratory distress.
This next one, I think they have some kind of cardiac history.
Mm-hmm.
That's all there is to this segment.
I had a migraine before this, and I just have a feeling that I'm gonna get a migraine after this segment.
These
I
are all
don't know why.
fictitious. They're all
I
fictitious. Don't worry.
don't know why we thought this was a good idea. They have some kind of cardiac history.
Yeah, it's just some kind of cardiac history. It's no big deal.
I'm gonna put it here. This feels good right
Okay.
there. That feels good right there.
All right, here we go. No Foley on a supercritical patient.
Are they intubated?
So they're supercritical.
Oh, okay. Because like putting in a Foley is not a huge deal for me, but I am gonna be pretty annoyed.
Yeah,
I'm gonna put,
and
like,
we can't get a
That's
temperature
quick.
on them either.
My God, so it needs to be a temp Foley.
Yeah,
Let me tell you what.
but
You
we
do
don't even
need
have
a
a
temp
temperature.
Foley.
Oh,
Okay, see, now I'm annoyed and I'm mad because like,
yeah.
how did you not get a temperature on your patient at all?
Well,
I'm
you
gonna
know, there
put
you
that.
go.
Yeah, I'm gonna put that like there. Actually, because I have a feeling it's gonna get so much worse. So I'm gonna give myself a little bit of wiggle room. I'm gonna put it like here.
Here we go. The tape job on their IV looks like an arts and crafts project, and not a good one. It looks like a
Because like
5-year-old
just
did it.
replace the Tegaderm. I'm not like that's not that bad. I'm gonna put that. That's honestly probably right in the middle. I don't really feel any kind of certain way about that. Me personally, I'm sure there's some that would hate that, but me personally, I don't feel a certain kind of way about that. Okay.
So we RSI'd this patient, and there's no sedation running on them.
Yeah, that's bad. That's bad.
I hate that. That bothers me
I hate
so
that.
much. I'm
Give
like,
people, listen, if
seriously,
someone
if we're
is
gonna intubate
RSI'd,
them, yeah,
intubate them, give them something to sedate them. I don't even care. I don't even care. Okay, we're about to open a can of worms because this will piss me off. The couple,
same.
like, if a doctor RSIs a patient and they're like, oh, well, they're not responsive, so we're not going to sedate them. Fuck off. Oh my God. No, that's like here. Everybody deserves sedation and pain meds if you're doing
Amen.
something like that. Fuck out of here. Okay.
No, and so this is one, like, for me as an ER nurse, I will never send somebody up without sedation. I'm sorry, you're sedating this
Like,
patient
and if someone's
before
tubed, you should always have some kind of pain med. You should,
you
even if
should,
it's like
because it's
25
painful.
of fentanyl, it's painful and you don't know what they're like realizing is happening to them. So like put people on pain meds and sedation.
Yeah,
That's
it's
what they
not
have
that
the
hard.
tube for. It's not that hard.
Yeah, and it's not like you're paying for them out of your own pocket, so just freaking give it to them. It drives me crazy, and I've had patients where they're like, oh, they're not really responsive. We're
Yeah.
going to intubate them. You intubate them, and then they start gagging on the tube, and now you
Yes.
have a aspiration problem. And you're like, well,
Yes.
congratulations, yeah, they just came out
You
of it,
played
and
yourself.
yeah, exactly. It's just a bad look. Like
It's just a
just tube
bad
them.
look. And it's already just so traumatic that, yeah, I hate that.
Yes.
Okay. I'm glad I saved that spot because
Yeah.
woof. Okay.
All right. Gives you the heads up. Hey, this one's going to be a problem.
Oh, love you forever. That's going to be like up here. Thank you for mentally preparing me for the person in, who has a bad attitude.
Hey, we already started sedation and pain control, and it looks like they're probably going to need pressors. So I've got that hanging, but not started yet.
Okay, so you're sending me a bag of the pressers, but it's
Because as
not
of right now, that
primed yet.
no, it's primed. It's primed and it's ready
Oh,
to
it's
go.
primed. It's primed. The
Yeah,
pump's
it's primed
set.
and
It's
it's ready
just
to go.
they just don't need it yet.
They
Okay,
don't meet
yeah.
parameters yet, but the doctor wanted to make sure we had something.
Yes, I love that. Save me the time from priming the line, having to pull it. Okay. Yeah, no, we're doing good. We're doing good. I'm a happy ICU nurse.
All right, the family shows up, 12 deep with zero boundaries.
Okay. Am I am I working my first 12 or am I working like my fourth 12 in a
I
row?
think that's your call.
So I have the type of autism that makes social situations really horrible. So, um like I'm going to be I don't know. Cuz like that wouldn't really make me mad cuz I am empathetic to the fact that they're like family and they don't like ICU is so scary for a lot of people that like I'm really empathetic to that like I'm caring for someone who they're having like the worst day of their life, right?
Absolutely.
But I wouldn't say I'm happy about it.
Yeah, exactly.
Like I wouldn't say that that's like walking into a room and it's like walking in to get report and seeing a crash cart outside of a room and you're like, "Oh God, please don't be in my room."
Okay, now on top of that, there are two of them planning to stay overnight.
Did they bring an overnight bag or am I going to have to be giving them stuff?
No, they didn't bring anything. They're from
They
out of
didn't bring
town.
anything. They're from out of town. Oh, poor babies. I'm gonna put that. I wouldn't say I'm necessarily happy about it, but I'm not mad about it. But it's
Yeah.
like not that bad. Like I like as long as they kind of I don't know. It's not bad. That's actually not bad to me. But I wouldn't say I'm like, oh yeah, there's a bunch of family. But just because depending on how sick the patient is, sometimes it's a lot.
Yeah. Now we'll go to the other spectrum here. I set the expectation with the family before transfer of what that's going to look like, and they know about the visiting hours, and they know that they're going to have to send back like one or two at a time.
Wonderful. Chef's kiss. And they're agreeable.
Yeah.
Yeah, that's like up here. That's like, yes, thank you for doing it. Not, you know what? Actually, no, because sometimes they're agreeable when you tell them until it actually comes time to leave. So I'm gonna put it slightly less.
I like it.
on the happy scale.
All right. Report feels rushed and chaotic.
I'm such an empath. I get it though. I mean, there is going to be like a slight annoyance, but again, personal problem. Talk about it in therapy.
Yeah.
I'm going to put it, I'm going to put it like here.
Yeah.
I think.
So we're going to test out your empath right here. I'm going to tell you,
God.
I've been with this patient nonstop and haven't been able to chart anything.
No, I get that. I get
Literally,
that.
they've just been so sick that I have all that's charted in there is vitals because they're pull over automatically, and I'm going to put in all my notes, but it's just been too busy and they're just too sick.
So definitely tolerable. I'm not necessarily happy about it.
For sure.
I'm not necessarily.
And that's a real world. That's a real world thing though that happens sometimes. Is like
it is.
If like from the minute they got there to the minute they leave the ER, it is just chaos.
Yes, because even
it's like,
I've had days like that.
Yeah.
Where like I'm like writing down shit that happens and at what time.
The worst part about this is though is that like when that happens, if I go and I take this patient to the ICU, by the time I get back to the ER, they've already cleaned that room and put a new bed in there.
Yeah.
And probably a new patient. And it's still my room. It's still my room that I'm responsible for. And I still haven't charted on that last one.
Yeah. Very tolerable. I will never
it's
hold that
super
against
frustrating.
you.
It's super frustrating when that happens. Like that is a real world problem in the ER.
But very neutral on the happy and mad. Like I'm not happy about it, but I would never be mad at you about that. Very tolerable because we're like right up here, like right at the top.
I think with that though, in order for it to be a tolerable thing, it's really giving the background on it and just taking the minute to say it to the ICU nurse like that.
Just being transparent. Like if I'm getting a report from you and you're like, look, man, like I've spent the last 2 hours in this room, like trying to stabilize them. Dude, for sure. Like bring them to me and it'll be fine. But I mean, I'm not happy about it. Yeah. I'm very neutral about it.
Absolutely. All right. And then the last one is, has the important stuff documented.
Oh, that's great. Yeah, no, we're like right up here.
So I think what we learned is that Courtney is pretty agreeable to things as long as they're within a range that is okay. Like it's like, we can agree that just allowing people to be people is okay.
You have the right to be people, right?
Yeah.
But don't come at me with, well, they're not like responsive and their LOC is like 3. And so we're not going to provide them with any pain meds when we intubate them.
Yeah. I just think that's so unethical.
I just think it's like an ethical thing for me. Yeah, I feel
Which
that.
In the ER, we counter this though by having clinical pharmacists at the bedside to where we don't have to think about this. It's like as soon as there's a critical patient, pharmacy's there at bedside and they're helping make stuff happen. And that is such a huge, great resource. And if you're a new nurse or newer nurse or you're somebody who's not super confident in your meds, talk to them. They are amazing. Yes. They know so much.
Amazingly smart people.
Yes.
My God. I learned so much from pharmacists.
And they can help with different things too. It's like if you've got a new patient who's going on Eliquis or something like that, and your patient's worried about the cost of a drug, they can help them out. They've got coupon cards. They got all kinds of stuff to help them.
Yeah, they have like
with that in education
to waive stuff. Yes. It's amazing what they have.
Yes, absolutely. Thank you so much, everybody, for joining us on today's episode of Crashcart Nursing. We're really glad that you came. Please remember to like, subscribe, share, comment. If you've got video ideas that you would love to see, we are happy to oblige. We're trying to bring more education to you. Obviously, we want to be funny. We want to have a good time. But more than anything, we want to help empower a future generation of nurses because that's really what we believe in. We're both educators and we care about making great nurses out of you. Anyway, thanks so much. We'll see you next time.
Okay, thanks, guys.
Be strong when you feel like giving up on everything and everyone around you.